All right, hello guys. We're going to be going over drugs for shock. Luckily, it's going to be fairly on the quicker side. So let's just get right to it. So for shock, right? By definition, what's going on here is that the body's basically unable to really get blood flow where the body needs it, right? So it's a direct alteration of perfusion. The whole thing with it is that it could lead to irreversible organ damage and death. The whole problem behind that is because as the body is basically trying to compensate, a lot of blood vessels will be constricted because you're basically shunting blood flow from those organs that are not I mean, they are vital, right? But they're the most vital ones we have is our brain and our heart. So more often than not, a lot of blood is shunted from, for instance, like our renal system, right, our kidneys, and our hepatic system, so our liver, and not to mention various different other organs as well. And it's all shunted towards the brain and the heart. So what's going on here, right? It's affecting various different types of systems, and we'll kind of go into it right? It affects our nervous system because that's kind of the first thing that's triggered when we go into shock in order to compensate. Renal, because again, since blood is shunted away, the kidneys, you can have an acute kidney injury, is pretty much what it's going on about. And then cardiovascular systems, right? And it makes sense because it's directly related to the cardiovascular system, with the most extreme being like cardiac arrest or vascular insufficiency or collapse or death. So the big thing is that, like by definition, right, shock, a condition where vital or tissue organs do not receive enough blood to function properly. Very simple. And then without oxygen or nutrients, those metabolic processes cannot occur. So it also causes like a buildup of lactic acid as well. It's a medical emergency, and luckily, it is reversible if treated quickly. You just have to act fast. So in terms of shock, we'll go into like the early symptoms and then also the late symptoms. So the big thing with the early symptoms, and this is kind of directly from the book, right? So our mileage can vary depending on how much we're going to have it shown in class. But one of the earliest symptoms would be tachypnea, right? And usually it's rapid and shallow. Another thing that can occur as well is tachycardia, but the pulse would be fairly strong rather than weak. That's a little bit for later. And then, according to the book, that's why it's in black because it's a little different. We have behavioral changes where you get restless, anxious, you get confused, depression, you could get apathy. And then some later symptoms. Now, this is kind of just more from what we know and understand of shock, right? Our blood pressure would be going low, right? Either because of the too much fluid loss or because of a severe drop in vascular pressure, right? Or vascular constriction that leads to the low blood pressure. Tachycardia, but at this point now it's thready and weak. And then there's altered level of consciousness, but then it could eventually turn into a loss of consciousness. And then we also have thirst as well. I would imagine thirst can also fall under early symptoms, but I guess it just really depends, if the person's dehydrated or whichever. But it makes sense, right? Thirst, because in this type of moment, when you're in shock and your body's compensating, since you're basically going into fight or flight, secretions are reduced, right? Because it's fight or flight. So we have less fluids being secreted, basically saliva in our mouth. And that's what could kind of trigger that thirst reflex. So here's the different types of shocks that we're going to have to know. And luckily in class, it seems like we were basically given the right answers for those types of issues, right? So for hypovolemic, right, it has everything to do with the loss of body fluids, or hemorrhagic, which is a type of hypovolemic shock that solely is based off of the loss of blood. So the nice thing about hypovolemic, for the most part, it's very straightforward, right? If there's a severe loss of body fluids, you treat with fluids, right? And usually it's normal saline, more often than not. That's like the initial treatment, usually. And then if it's a hemorrhagic, loss of blood, obviously if a person loses blood, you just replace with blood. Now, for neurogenic shock, that's a little different, right? So our body is always constantly working in homeostasis to kind of keep things balanced, right? Whether we have vasodilation or vasoconstriction. So let's say, for instance, a person's their neck, right? They unfortunately their spine got snapped, and then now the messages aren't really being sent. So by default, our body kind of just goes into vasodilation rather than constriction because it's always being kind of modulated that way by our CNS. The whole issue is that since messages aren't really being sent by the brain through the spinal cord to the peripheral, uh, vasculature and everything connected to the nerves, that that ends up leading to an extreme vasodilated kind of effect, right? Because the messages aren't really being sent. So chemicals aren't really being sent past the synapse to say, hey, let's go ahead and vasoconstrict. So that's where, usually it's from spinal trauma, as mentioned, and bradycardia can occur as well, because again, you're basically preventing, for instance, I guess we can say fight or flight, right? A sympathetic nervous system response from occurring. That's where the bradycardia can occur. You're essentially, with neurogenic shock, you're just stopping or canceling out any type of effect of the sympathetic nervous system or the fight or flight. So one of the biggest fixers for this type of shock is thankfully very straightforward. It's vasopressors. So those are the big ones in order to address this type of shock, because it's not really a fluid issue. It's a vascular pressure kind of issue because of the constriction or loss of vasoconstriction. As for cardiogenic shock, more often than not, it's talking about a failure to pump blood, and it occurs mainly from an MI, but it's not just limited to an MI, it's also including things like heart failure. When a person's blood, heart can't really pump efficiently in order to properly perfuse to the rest of the body, that's where issues can really come about, and cardiogenic can occur because at the end of the day, it's just failure to pump blood, whether it's an MI or heart failure. Um, the biggest thing with this is that you are not to give fluids for this type of shock, right? Because our heart, like, right, let's say for instance, heart failure, right? Should heart failure patients be getting fluids? They should not, because their heart can't take it already as it is. So therefore, giving them more fluids is just going to make the situation worse. I guess in another kind of area to look at, you probably wouldn't give someone who's currently having an MI, not a full arrest, not a cardiac arrest, but an MI, right? So right now, the one of the great vessels, or one of the arteries in the heart is occluded, right? So it's causing that ischemia, that's causing that infarction, right? You probably don't necessarily want to be giving vasopressors at that time, right? You would be giving vasopressors, for instance, if someone goes into cardiac arrest, because at that point it's full cardiovascular collapse and you needed to maintain a pressure. But from how I'm understanding, at least when it comes to things like, uh, something like an MI, it's not necessarily full blown ideal. Again, mileage varies, but at least that's kind of how my interpretation goes about it. But for sure, like for somebody having like a cardiac arrest, they would be getting epi. For somebody who's having like heart failure, for instance, they would be getting dobutamine. That's where that's coming in, because dobutamine is a direct beta 1 agonist, right? So beta 1, right? One heart. That's where that's coming from. For instance, something like anaphylactic shock, which we've seen before, right, in first semester, it's just a severe allergic reaction to any type of allergen. It leads to severe bronchoconstriction and vasodilation, but vasodilation to the point where, it can kind of facilitate a person choking to death because of a closed airway. So for those, the fix is usually epi-IM, right, injection, and at times vasopressors can also be used as well. Now on to the next one, septic shock. So it's an infection that basically makes its way into the blood, and it often dehydrates patients as well. For the fix on that one, because it does cause, like, our body, when we have this major immune system response, all these types of immune modulators or things that are in charge of those, they lead to a crazy big like vasodilated effect, because what it's doing, it's all chemical messaging that just triggers more dilation, because the whole point is to bring more blood, ideally. But in the end, all it does is just over dilate. You don't have enough fluids to compensate for that dilation. So the pressure drops, the blood pressure drops severely. So the main fix with these is antibiotics, obviously, for the sepsis. But then initially it will be 2 liters of normal saline, but then hypotonic fluids, mainly, given for the dehydration. And vasopressors are also applicable for septic shock because, again, it's this over dilated effect. So that's kind of one way we can kind of tackle these types of problems, right? Problems that have too much dilation will probably require a vasopressor in addition with fluids, because fluids are applicable to all shocks except cardiogenic, right? Because for cardiogenic, the heart can't really take it because it can't even pump the blood. to begin with. But usually, and this is what was said in class, an initial 2 liters of bolus, right? So it's just free flowing of NS max, but then after that, it's followed by a slow infusion of hypotonic normal saline. That's at least what was stated in class. But now, kind of going back to it, right? Problems that have over vasodilated effects that probably benefit from vasopressors would be things like neurogenic shock, anaphylactic shock, and septic shock. I would imagine that's how it goes because these three right here, CNS, we can kind of use it to remember, are the ones where there's too much vasodilation. While in things like hypovolemic shock, there's more of a loss of fluids, so you fix with fluids. And in cardiogenic shock, there's just a problem with the pumping action of the heart, whether it's being prevented from getting blood flow to the heart by ischemia in an MI, or there's just genuine acute heart failure where the heart just cannot contract strong enough to get that pressure, to go and move blood into the aorta and then the rest of the body and so on. So that's kind of how that's going on that. And then this is just, color coded to, from the last thing just to make things a little bit easier. But these are just various different examples. Perhaps we would have a test question that asks what is it like are some examples of I don't know, neurogenic shock or what causes it, probably things like that. Or probably a matching, yeah, very likely. We've seen it before, right? And it kind of makes sense because these are kind of interesting things to see, like the connections and why is it caused. But like, let's see that cardiogenic, like left heart failure, MI, right? Dysrhythmias makes sense. There's a lot of different things going on, so it's not just limited only to like vascular ischemia or there's full blown like heart failure. There's also pulmonary embolism, the dysrhythmias as well, right? Because when a heart is in a dysrhythmic kind of tone, they can't really compensate that well. But everything else is kind of straightforward, pretty clear. Cardiogenic might just be one of those where it's like, oh, we have to just look at it a little further. So here's the stages of shock. So the first stage would be neuronal compensation, right? So our body is in this panic mode, right? We kind of acknowledge it. We understand, oh, there's something wrong, right? So all that's really going on is that it's an initial sympathetic nervous system response that triggers fight or flight, right? We've saw about it. Fight or flight will attempt to bring up our heart rate. It will vasoconstrict as best as possible, typically. In order to increase pressure, the heart will pump harder, kind of things like that. We will breathe faster, a little bit shallow, trying to get more air into there. That's where that comes in. But there is a cap to that. It doesn't necessarily hold the person over for that long. So eventually, we have to kind of just revert into endocrine compensation, right? And that's our second step. So the adrenal medulla releases norepinephrine and epi. Norepinephrine targets alpha 1, alpha 2, but it's not really going to be paying a lot of attention to alpha 2. So alpha 1 is the most important one we got to know about. And alpha 1 is all about vasoconstriction. That's its job. And it, targets beta 1 as well, which is all about increasing heart rate and pumping action. And then epi triggers all alpha 1, alpha 2, beta 1, beta 2, but we're mainly focusing on the aspects of alpha 1, beta 1, and then beta 2 because beta 2, 2 lungs, kind of helping out with the air. The posterior pituitary also releases antidiuretic hormone, mainly to kind of preserve our like fluid or what we have inside as fluids. It's so we don't pee as much, right? One of the classic symptoms of shock is low urine output. And the RAS activates, right? Or renin-angiotensin system activates, basically releasing various different types of steroids, mainly aldosterone, because it increases um, the reabsorption of sodium, which water will follow, and we leave out things like potassium. So what all this is really trying to do is either increase the action of the heart or the cardiovascular system, and by also respiratory system as well with epinephrine. And then things like antidiuretic hormone and aldosterone, they're mainly tailored to keep our fluids within ourselves so we can keep the pressure up and not lose fluids. But eventually, we do have our third set, which would be chemical compensation, right? So when a person is in shock, we've talked about this a little bit earlier, lactic acid builds up and it occurs due to the ischemia. Tissue dies, and then once the tissue dies, then a lot of lactic acid kind of gets built up because necrosis could occur, right? So our body kind of goes into this, or doesn't really kind of, it goes into it. The body goes into metabolic acidosis. And the body quickly will compensate by tachypnea, because if we have a lot of acid that's throwing off the acid base balance of bicarb in our system, that will make us, right, our bicarb is low either because the bicarb by, is kind of undergone just because we have way too much CO2 buildup. So our body will try to do a lot of respirations, very quick and shallow, in order to blow off any additional CO2. And this happens because the kidneys can't really reabsorb bicarb fast enough to compensate. So usually your respiratory system is the first thing to do in order to um, compensate. So just to review, right, we first respond by central nervous system, then we use our endocrine system, and then finally we have to use our acid-base balance through chemical compensation. And this right here is just kind of like a quick little thing, just right. If the blood pressure drops and the cardiac output drops, and it's occurring because of, like it's a loss of like heart function, then more often than not, you need vasopressors or inotropic drugs. That's where this comes in. If there's a loss of blood volume, whether it's fluids or blood, that's where your colloids or your crystalloids will come in, because it's just kind of going. It's fairly simple. It's a pretty good little grid right there. So initial treatment priorities, right? The ABCs of life support are the most important because they're the thing that's going to preserve the patient. Um, right? So airway, big thing. Intubation may occur first. I mean, more often than not, if a person's pulseless, chest compressions will occur first. I guess it's just kind of we just have to see which is occurring first. If the person stops breathing and the heart's still going, it's not going to take very long for their heart to just stop as well. Both systems are basically tethered together. If the heart goes out, the respiratory system will go out, and vice versa as well. It just kind of depends. But if the person's pulseless, the first thing you have to get on is chest compressions in order to kind of perfuse whatever else is available. But intubation can also occur first, just kind of one of those that will happen at the same time kind of thing. Um, and then another thing too, for like we'll also have fluids, right? They apply to all shocks except cardiogenic shocks. So just kind of be aware of that one. Um, so big thing too, we have to connect the patient on a cardiac monitor and a pulse ox. That's just kind of standard, and I think we'll have questions like that. I feel like there's going to be a quick little one where it's just going to say like, patient is in compressions or something, and like, what's the next step? Well, once we're actually doing the ABCs first, the next ideal thing would be to put the patient on the monitor, because without the monitor, we can't really tell what's going on, at least in a heart kind of rhythm kind of sense. Administer oxygen at 15 liters per minute, right, with a non-rebreather mask. Who the heck knows if we're gonna have a question about like the reservoir bag or something, or either that or like a BVM. We have to let the reservoir bag inflate first, right? So who knows if that'll come up. Keep the patient warm and quiet, mainly just giving that psychological support. And the reason why you keep them warm is because there's a lot of vasoconstriction occurring. And that vasoconstriction is all because blood is being shunted away from basically all the peripheral vasculature towards those vital organs of the heart and the brain. And all that vasoconstriction, right? When our vessels get too small, we can get cold. That's why inversely, when we're really hot, our blood vessels dilate, so we sweat, and then we feel like, gust of wind, and that kind of cools us off. But in this case, that vasoconstriction requires us to keep the patient's temperature up. So our goals, right? Mainly, it's just restoring that normal fluid volume. Either that or keeping the pressure up. Those are the most ideal. For anaphylaxis as a bonus, we have to prevent or stop that hypersensitive inflammatory response. That's why the epi is the most important. I mean, it'll probably be, following up with, things like Benadryl perhaps, but fluids help, but they don't really solve the problem. That's the whole thing behind this. Epi is the most important because it will give that alpha 1 effect of vasoconstriction to kind of help out that airway to kind of get bigger, because the whole point of, again, with an anaphylactic reaction is that all the vessels dilate so big, kind of facilitates you basically choking to death. So you want to, the problem is too much dilation. You want to bring it down. And then the whole problem too is that we have too much bronchoconstriction that can occur as well. That's where the epi helps with alpha 1 to vasoconstrict, like especially those vessels in the neck and the respiratory system as well. And then beta 2, because beta 2 helps out with that vasodilation or that bronchodilation for the respiratory system. And then like helps you out with breathing. So that's why it's the most important. The real solution for anaphylaxis is epinephrine, IM, right? So this is kind of like our little track flow, kind of understanding what's going on. It's kind of what I gathered from things from the book and lecture and everything, right? So blood or blood products, the main thing is that those are obviously indicated for severe loss of blood. Pretty straightforward, right? Packed red blood cells are the most ideal, but be aware that fluids may be given first. But that those packed red blood cells are very nice, right? Because it's more red blood cells than it is fluid, so you don't like over, flow the patient with like way too much fluids, right? But if they're bleeding, for instance, and not just that too, packed red blood cells really ideal for people who are having like really low like oxygen perfusion, right? Because more red blood cells, more like blood cells with ready oxygen to give for the rest of the body. That's kind of another reason why it's ideal to use that one. Um, if the person's bleeding, we can have fresh frozen plasma, mainly because it has those clotting factors to help out. And then colloids for low vascular volume because they're very hypertonic and they will pull fluids from the rest of the body into the intravascular space, right? So here's another thing. So when the problem is of preload or volume, you give fluid resuscitation. And if the issue is a fluid, like a fluid or electrolyte imbalance, or metabolic, like an acid base imbalance, fluids are enough to treat the issue. That's really what's going on, right? And as mentioned before, if it's a blood loss issue, then obviously blood products are going to be the most ideal. Now, for instance, let's say cardiac function is compromised, things like heart failure, things like dysrhythmias, things like various different things going on, right? An MI or things like that, usually, but we're mainly talking about this, at least like impaired cardiac function. We're mainly talking about like heart failure, because for heart failure, you would give an inotropic drug because dobutamine, as mentioned before, is that beta 1 agonist that will trigger the heart to pump a little harder. And it's not like digoxin, because digoxin will also lower the heart rate. You kind of don't want to do that in this case because late term shock will have a drop in heart rate. Probably not the most ideal. So dobutamine, that's the main indication with it. Dobutamine will help pump up the heart action because it directly triggers beta 1. Now, there's a loss in vascular tone, right? So basically, what it's saying is that you have overdilation of the blood vessel. The first, you're going to need a vasopressor, and the first thing you're going to use is norepinephrine. And we'll find out why, because norepinephrine is like that universal standard treatment. It's kind of the safest one. It's sort of like that universal one that will keep the blood vessel constricted. What's up? Oh, and we have it ourselves, but we do kind of need additional fluids. That's why, but it's mainly given in ICU kind of situations. This is critical care. This is like they need it. In fact, they can only live with it, like in very very severe situations in an ICU kind of context. Um, but yeah, we have it, but it will really only hold us over. At some point, you just need it right into the vein. Um, and then for number two, we have phenylephrine, which happens to be one of the drugs that we covered last week. But the big thing is that phenylephrine, it's basically synthetic norepinephrine. Kind of the simple, like that's oversimplifying it, but that's really what's going on. It's pretty much just synthetic. It doesn't work as good as norepinephrine, but it could be used as a second line treatment, or perhaps I'm not too sure, but I would imagine it could be used in addition with it, like an adjuvant to kind of help out. But that the most ideal would be norepinephrine. That's like if we're gonna end up with like a question where it's like the patient has lost severe vascular tone, which of these four drugs is ideal, or the one that like will really help them, norepinephrine would be the one. Now for things like dopamine, it's dose dependent. We'll go over it a little bit later. Not the most ideal according to our professor, right? Mainly because it has a lot of risks involved with dopamine, especially with high doses, because high doses will do what we want, but it will also cause problems as well. And then fourth, epinephrine is basically a last line drug. It will only really be used in situations where the patient is essentially practically dying. So for crystalloids, this is just like a quick review because we've kind of gone over them, right? But they can readily leave the blood and enter cells. They can also do the opposite. They could pull they could pull fluids from the surrounding tissues into the blood vessel. They can do, as mentioned, the opposite, where now fluids are going from the blood vessel into the like cells. It just kind of varies, right? And then there's some where they'll flow in and out in between them, right? Are isotonic, hypertonic, and then hypotonic, right? And they're mainly just to replace those fluids that have been lost to promote that urine output. That's the whole point, right? Get fluids going through the kidneys because the kidneys need the fluid as well in order to keep that function to prevent that acute kidney injury. And then there's just various different examples like normal saline, which is isotonic, lactated ringers, which is also isotonic, plasma which I believe is isotonic in certain numbers, but there's also hypotonic plasma as well. And then there's hypertonic saline, usually that 3% NaCl. Normal saline is that point, and that's 0.9%, right? And then if you give 2 liters of fluids, usually that normal saline, and the blood volume or the BP is still too low, you give colloids, right? Colloids will maintain that plasma osmotic pressure, right? Because they're just special proteins that can't really leave the blood vessel. And because they're proteins, they're very hypertonic. They have a high tonicity, so they will pull fluids from the surrounding tissues into the vessel. And the main use is for that restoration of plasma volume and blood proteins if you were to be low on albumin, for instance. Um, but be aware there is a capacity of how much you can give. You can't just overload a person with colloids as well. And that's where we have our normal serum albumin. Luckily, they kind of have that nice name of albuminar or plasbumin. Pretty straightforward name. Mechanism of action, right? It's basically what we just talked about earlier. It's just hypertonic and it'll pull fluids from surrounding tissues into the blood vessel itself. Primary use, right? Restoration of that blood volume, plasma volume, and then the proteins, basically what we talked about earlier. Adverse effects are allergies because this is a blood product. Can happen. And then protein overload because it's a protein. So you can also overdo it too. And then in real world application, this was said in class, consent is not always needed. Not sure if that'll come up on a question, but like at least in real world. That is weird, yeah.
The book said it's a blood product.
No, because it is a blood product, straight up. But like,
She said it was an animal, but it was a human. Whatever.
yeah, no, yeah. So that's a little weird on that one, but I can kind of see where the whole consent is not always needed because sometimes you have to go through implied consent. Kind of weird. I don't know. I just know the book answer is if they're a Jehovah Witness, even if they go down and it's like implied consent, you still don't give it. Yeah, because yeah. So that's what I'd go with, I guess, on a test. Now, as mentioned before, we have our highlights. So our highlights kind of help us differentiate things. Blood products, anything in green is basically a blood product. That's where the plasma protein fraction. That's a blood product, even though it's a colloid. Albumin is a blood product as well, but you know, artificial colloids would be that dextran and hetastarch, right? So that's where that comes in. But we've seen these before, so I won't bore you with those. Let's just get right to the actual vasopressors, right? So our mechanism of action for vasopressors, the biggest thing that we're really looking for in terms of vasopressors is, I mean, it's as simple as like the name of it, vasopressors. And in our adrenergic receptors, the one that directly is all about like, vasoconstriction throughout our entire peripheral vasculature is alpha 1. That's what we're really looking for because the idea is for this to keep the blood pressure up by that vasoconstriction action. So these are basically agonists. They're alpha 1 receptor agonists. Long story short, like there's different names to call them, but to be simple, they're vasopressors, right? They treat shock, right? And various different types of shocks. We went over the ones that typically require them: sepsis, not cardiogenic, sorry, Sepsis, well, cardiogenic depending if it's a cardiac arrest, but that's where epinephrine comes in. Um, but yeah, we went over neurogenic, septic, and blanking out on that third one that was also indicated. But um, as long as you just think of too much vasodilation, that's where that's coming. But examples, right? We have dopamine, norepinephrine, phenylephrine, and epinephrine. So we'll start out with the first line, right? We said norepinephrine will be our first line treatment. It's the thing that will help out the most. Norepinephrine will trigger alpha 1, it'll trigger alpha 2, but we're not paying attention too much to alpha 2 because this is an emergency. Alpha 2 is all about chilling out the body. We're not really trying to chill out the body right now because if they do, they might just die. And then beta 1, they could trigger beta 1, but they're not the most strongest to do beta 1, but it's possible. And that's the reason why over here, right? It's a choice drug for IV vasopressors with less dysrhythmia risk, and it mainly causes tachycardia because norepinephrine targets beta 1. That's where it's coming in. It can cause that tachycardia. That's what at least was said in class. Kind of makes sense because since norepinephrine will trigger beta 1's all about increasing that pumping action and the heart rate. Kind of makes sense what tachycardia can cause, or it can cause tachycardia, I mean. Now, our next line of drug, right? Phenylephrine, we kind of went over it a little bit last week in the slides. Sorry that the video weird things happened, but it's a second line treatment because it's just not as effective. It's synthetic norepinephrine. There's just something about it where if it's direct norepinephrine, it's going to do you great. If it's just synthetic, it might not be as great, right? That's pretty much the main takeaway. And we went and kind of over the whole thing where like phenylephrine can help a bit, but it won't do like crazy stuff. It's mainly helping out for that alpha 1 thing, even though it does have the capacity to do beta 1 and 2, I guess, because of the slides how they were set up last week. But really, we're mainly focused on alpha 1, and it's just not as effective. If we're going to choose between the two, we're going to go with norepi. Now, on that third one, we have dopamine, right? And it's generally not used with others. That's at least what was said in class. The whole thing with dopamine is that it's less ideal because it could cause many types of dysrhythmias. And these are the example of dysrhythmias that I looked up online that they can cause. They can cause sinus tachycardia, which is probably the healthiest one of all of them, even though you shouldn't be in that all the time. They could cause AFib, they can cause a flutter, they can cause SVT, they can cause PVCs, VTAC or VFib. Now, these VTAC and VFib are deadly rhythms. Those are the ones where you're now in cardiac arrest. So that's why dopamine, not the most ideal use, but we're going to see why dopamine is kind of helpful in lower doses, not really the high doses. It's not the most ideal drug to use because of the risk behind it. And then finally, we have epinephrine. It's used as a last line IV vasopressor for situations like cardiac arrest, things like anaphylaxis, but you give it IM, right? In cardiac arrest, you give it IV. In anaphylaxis, you give it IM, and it will situations like profound shock. So basically, any situation where the patient is legit like actively dying, and then abrupt DC of basically norepinephrine or epinephrine can kill somebody because your body is now at that point dependent on that supplemental epinephrine or norepi in order to keep the pressure. So if you just quickly, abruptly stop, which I feel like might be a question if you think about it, that might kill somebody. That might put someone over the edge. So the idea is to wean them off slowly. All right. So Levofed is going to be our name, right? Our trade name. Now the big thing is that I did highlight or box these, underline, whatever, in different colors. So dark green will be for alpha receptors, and we're mainly talking about alpha 1. And then so norepinephrine, right? It triggers alpha 1 to basically cause that immediate, vasoconstriction to raise blood pressure. It also, at a lesser degree, stimulates beta 1 to make that positive inotropic response, so basically bumping up the heart rate and contraction of the heart. Its primary indications are the acute shock or cardiac arrest. Right? Another thing too is that it's very helpful for septic shock. Right? And so it is given by IV route, and it has only a duration of 1 to 2 minutes once the infusion is terminated. That's why you should not abruptly discontinue, because again, what if a person is just dependent on it, then you stop it, they're basically going to go back into full arrest. Administration alerts. So the big thing with norepinephrine, and you'll also see it with dopamine, this drug is a vesicant. Start the infusion once after ensuring the patency of the IV, right? And then monitor the flow rate, monitor the rate very, very, you have to just watch the flow rate, right? Like watch the patient's blood vessel or their IV site, right? Because if extravasation occurs, then you can cause severe tissue damage. Because imagine the whole point is that you're basically putting vasoconstrictors in the vessels in order to get it throughout the whole body. Now, imagine if it was just localized to only one little area in the body. That's going to cause like severe like necrosis because you're going to constrict everything. And if it were to happen, you give phentolamine, which is an alpha 1 blocker, right? It makes sense. You have an alpha 1 agonist, you give an alpha 1 blocker if extravasation occurs. And you do it in the area of infiltration. If I recall right, it's usually given intradermal. Not 100% sure, right? But our whole process, according to our book, right? If extravasation occurs, we stop the pump. I don't know how the hell that's going to work because maybe you're going to have to start another line somewhere.
Use the same line.
Oh no, I mean like what, like for instance, let's say because if you abruptly stop this, they might die. So I'd imagine like someone else is working on getting another line, continuing it there. You definitely don't pull the line, right? Because it's infiltrated. You aspirate as much as possible, then you inject like phentolamine, and I saw it was intradermal.
Yeah.
So that's how I would imagine, because the whole idea, this is a part of critical care that I'm like, oh crap, because you don't want to just stop it because now they're gonna die.
Yeah.
So now I'm wondering like maybe that's how they do it, right? Because aspirate, that was a big thing with extravasation. You aspirate, then you give the
I'm trying to
solution.
think about the red book. The red book said take off the right, like stop the infusion, take off the line, use your IV, inject the phentolamine, let it sit for however many minutes, then pull everything out.
Oh! I thought it was aspirate then give phentolamine.
I thought it was. It might be that.
Something like
We
that.
have
Some
to
something
go
like
back to that red book, but
yeah.
who knows if that's like this though? Who knows?
We're gonna give the blank.
Yeah.
We're gonna give the blanket answer. Check your hospital's policies. Okay, but probably somewhere around that, right? But there it is. Look, do not abruptly discontinue infusion. That's like the yeah. So yeah. Category D, which just keeps going into the theme of basically every drug we've had in advanced pharm is not really safe for pregnancy. And then the IV route is the only choice. It could be given through peripheral IV initially, but there's a big margin of error. So eventually, there's a big margin of error for extravasation. So eventually, it has to be moved into a central line. Right?
That's crazy.
Yeah. So for adverse effects, so in class this was said, who knows if it's going to come up, but I mean, it's kind of interesting to know, right? Important assessment that must be done for the adverse effects that happen, right? People's extremities can become purple because too much vasoconstriction will cut off blood flow. So the whole thing is to market any purple areas with a Sharpie to note worsening perfusion or basically tissue necrosis. You definitely want to do a really good assessment. Check cap refill, check pulses, establish a baseline. And then if it keeps getting worse, then obviously, because I feel like, with this is going to happen. They're on vasopressors, right? The idea is let's hope it doesn't get worse. I guess that's kind of where we're catching it, right? For norepinephrine, right? It's a powerful vasoconstrictor, and continuous monitoring of the blood pressure is needed, right? Because hypertension can definitely occur. When you first give it, reflex bradycardia can occur. That's the whole problem behind it, because let's think our body just vasoconstricted like crazy, right? And the onset is immediate and it just vasoconstricted really, really hard. Now, too much blood pressure, like the blood pressure can really spike. Now, how our body would compensate, right? If we have way too much of a blood pressure, our heart might see that and say, I don't want to contribute to it. Even though heart rate doesn't really have like a giant jump for the blood pressure, the body will compensate really high blood pressure in the peripheral vasculature by slowing the heart rate down because it doesn't want to contribute to the blood pressure. So Be aware of reflex bradycardia, which was actually one of the side effects of phenylephrine as well. So kind of, it's following a pattern here. It also can cause those dysrhythmias that we've talked about, but they do it less than like other vasopressors like dopamine. And then if extravasation occurs, there's that serious skin and soft tissue injury. Blurred vision and photophobia can occur as well. Kind of makes sense in a way, right? Because now let's think about it. This is a vasopressor. We have alpha 1 receptors in our eyes. If we constrict those alpha 1 receptors in our eyes, that increases the pressure. You get overdilation now of the pupil, and you can maybe even make someone go blind. That's probably where it's coming from. That's where the photophobia is coming from, right? Too much mydriasis, and then the blurry vision, either from the photo or like light or some, but that's where that's coming in. Black box warning, extravasation, phentolamine. We already saw that, so you can just go ahead and skip that. Contraindications, they should not be administered to patients who are experiencing hypotension due to blood volume deficits, right? This is a vasoconstrictor. Now, I'm not sure if you guys have seen someone basically squirting out blood like from an injury. The whole reason why the blood is squirting out is because the blood pressure is, fairly high or like, even normal. Blood like blood will squirt out. Now imagine you just gave someone who has an open wound or an active bleed and you gave them a vasoconstrictor that's just going to increase the pressure and push blood out even harder. That's probably why you don't really want to use it on somebody who's having basically hypovolemic shock or hemorrhagic shock. You have to replace those fluids first and then address the bleeding. Well, address the bleeding first, then give fluids, or give both at the same time. I don't know. At this point, I don't know what those are just the solutions. At that point, it's like, let's see how the test goes. But the big thing too is that norepinephrine can cause severe peripheral and visceral vasoconstriction with decreased urine output, because again, our body, when we go into shock and we compensate by it, right? We release norepinephrine. And we talked about what happens when a person goes into shock. You shunt blood from other organs. We're talking about the kidneys mainly here, and you're shunting it towards the vital organs, the heart and the brain. So, giving this additional norepinephrine is just going to increase that activity. That's why INO monitoring is so important, especially I would imagine in the ICU, right? Things like mesenteric or peripheral vascular thrombosis can increase worsening ischemia and infarct, which is basically ischemia, but infarct is now like dead tissue because of the ischemia. So that's where that's coming in. But that's why we have to be very mindful about INO monitoring while giving norepinephrine, because they can cause that, shunted and shunted blood flow to the kidneys, and then now it's very low, and then the acute kidney injury can happen, and now you have a whole different problem, right? Drug-drug interactions, alpha and beta blockers may antagonize the vasopressor effects. Kind of makes sense, right? Because especially alpha blockers, those are the big ones to really be mindful about. Prazosin, right? If I recall correctly, those are our alpha blockers. Conversely, ergot alkaloids, basically, let's think of Imitrex, sumatriptan, or tricyclic antidepressants increase vasopressor effects. But if we can recall, our sumatriptan, all it's doing is that it's causing vasoconstriction in the brain. So that's where that's coming in. MAOIs can lead to an acute hypertensive crisis. Kind of makes sense. You can't take MAOIs with basically anything because you're going to explode or something. Treatment for the overdose, discontinuing the infusion causes a rapid reversal, right? Because we said the drug only really lasts like 1 to 2 minutes after you discontinue it. So it will reverse that hypertension, but now you're going to have a big problem because of like that, extreme vasoconstricted effect. Now, if you stop it and your body is too adjusted to that, your body's going to go into default mode, and it's not going to compensate by making its own norepinephrine fast enough. It's going to cause too much vasodilation. So you're probably going to have to replace the vasodilation because you can't use vasopressors. The only other way to fix the pressure is by basically flooding the patient with fluids. Now for inotropic drugs, we're mainly talking about, in this case, dopamine But our other inotropic drug is dobutamine. But here's dopamine. But I would imagine it would be good to know just about dobutamine a little bit. But here we're talking about dopamine, right? So low doses will have a dopaminergic effect. We'll kind of go into like a little bit of what's up with that. And then high doses will have a beta adrenergic effect. They treat hypovolemic shock and cardiogenic shock. So in a way, it kind of has similar actions to like epinephrine. In a way, not saying this is definitely something to use for like someone with anaphylaxis. No, it isn't. It's just it has similar action to it. Is what I'm trying to say. Um, and cardiogenic shock, right? Because of the beta agonist. That's what we're really caring about. That's the big thing, right? So hypovolemic and cardiogenic shock because of that beta adrenergic thing. Adverse effects are the dysrhythmias, and we talked about which ones. They could definitely cause hypertension and gangrene, mainly because of the extravasation or extreme vasoconstriction that decreases blood flow to limbs and kills off tissue. So, for dopamine, it is an immediate metabolic precursor to norepinephrine. It is a sympathomimetic, and its mechanism of action is completely dependent on dose, which is why I color coded it, right? Low doses selectively stimulates dopaminergic receptors in the kidneys that do vasodilation, that increase blood flow through the kidneys. This is essentially protecting the kidneys in a way, right? Because during when someone is in shock or being given norepinephrine and stuff, that blood flow will be shunted away from the kidneys and you can now cause a acute kidney injury. So it sounds like this drug is more like a support drug to prevent like acute kidney injury. It sounds like that's what it's doing.
Did she say not to give it with anything else?
That's the weird part that I don't understand. But like she said, yeah, don't give it with other things. So I'm not really sure what to do that with there, but I would imagine that this would be just like one of those really, really low dose kind of things. Like you give an extremely low dose or like the lowest dose possible just to protect the kidneys because now again, if the kidneys go out, then now you have a whole different problem and stuff. I don't really know. I mean, I don't have any critical care
Maybe she
experience,
was
but
talking in real life.
probably.
That's the thing. Sometimes she'll
Yeah.
talk real life and she'll talk book, and it's like
Yeah, so
we need you to be more. We need you to say when you're talking real life versus book.
yeah, so it gets a little mixed in there. I would imagine through the book,
Yeah.
the book answer
Yeah.
is it will help out with this. And I would imagine that's the most ideal use because now we're going to talk about over here high doses. Dopamine stimulates beta 1 adrenergic receptors that cause the heart to beat even harder and increase cardiac output because of that, tachycardia. Because and it also has the ability to stimulate alpha 1 adrenergic receptors. So again, it has that universal receptor touch like norepinephrine does to do that vasoconstriction and rising blood pressure. Now, the whole problem behind this is that we saw the dysrhythmias that this type of drug can do as well. So, probably again goes hand in hand why it's not the most ideal drug, but it is one of the many different ones, but the most ideal is norepi. This drug is given as a continuous infusion only, makes sense, just like norepinephrine. This drug is a vesicant, and basically this is just a repeat of norepinephrine because these drugs are vasopressors. They can cause a lot of tissue damage that way. And this is a category C drug. Makes sense because everything is dangerous. Adverse effects, right? Dysrhythmias. We went over which ones they could be. Hypertension, right? Makes sense because of the vasoconstriction, mainly with high dose. Dopamine is that vesicant that will cause severe irreversible skin damage or tissue damage if it infiltrates. Crazy. Black box warning, same warning, extravasation, give phentolamine. Dopamine is contraindicated for people with phytochromocytoma or chromocytoma, which is just a tumor at the adrenal glands that causes more release of norepinephrine, like an excessive amount. Or VFib, because this drug causes VFib or VTAC. So, like again, that's why like you don't want to give it when someone's having a dysrhythmia because now it's going to contribute to the probably fatal dysrhythmia. And then finally, our last slide, drug-drug interactions, MAOIs, same thing as norepinephrine, acute hypertensive crisis with MAOIs. Funny enough, phenytoin may result into hypotension, kind of interesting. But at this point, phenytoin basically interacts with everything. It's like digoxin. Digoxin interacts with everything. Phenytoin interacts with everything. Beta blockers. Long story short, this is just a repeat of the same thing. Beta blockers or alpha blockers are basically going to stop the effect of dopamine. That's not really anything new. It's like the same thing that we saw with norepi. And then the use with antidepressants or antipsychotics may decrease the effects of dopamine, mainly antipsychotics, because antipsychotics specifically target dopamine 2 receptors. Obviously, so those are dopamine antagonists. This is dopamine, so you're gonna, yeah. Treatment of overdose, right? Discontinue the infusion, makes a rapid reversal of the effects, such as hypertension. You could give phentolamine. Now, I don't know if it's like phentolamine IV, phentolamine a PO. I don't know what they were talking about that there, but they're just saying you can give phentolamine. And in class, professor did say you can also give antihypertensive drugs because you're mainly caring about the hypertension. So that's pretty much it with this video. It was pretty much like a kind of like a quick rapid fire one. It's
Can
a
you go
little
back
bit
to the
more.
North B extravasation thing?
Oh yeah, yeah.
I'm gonna stop it, okay?
Okay.